Welcome everybody. Welcome the whole Metro Teenage team. We didn't expect a third person, but it's wonderful. You'll see that they have their own evaluation. Please try to give them some specific feedback in addition to the colored copy eval we have given you. Both can be deposited at the bin on your way out. But this is going to be a very interactive session. So get them just done. I'm sure they'll be asking you to talk and ask questions.
You can talk with your mouth shut too, as long as we can understand you. All right, you ready to go?
All right, I'm very much ready.
No. We'll take turns.
Yeah.
So, good afternoon. I hope everybody's had a really interesting day so far. My name is Eliza Sarako-Polner. I'm the Capacity Building Coordinator at Metro Teenage.
I'm Leandria Gilliam. I'm the Capacity Building Training Manager at Metro Teenage.
So how many people have heard of Metro Teenage before? A few. Okay, so that's good. Where is everybody coming from for the most part before we get into what MTA is doing?
Unity.
Unity? Unity?
Montgomery County.
Okay.
Main clinic, yeah.
Okay.
Downstairs.
Sorry?
Downstairs.
Downstairs, okay. We have a lot of clinical focus here. So Metro Teenage is a community-based organization. We're located in Southeast DC. We serve youth ages 13 to 24, primarily in wards 6, 7, and 8, because that's where we're seeing high rates of HIV epidemics. We are an HIV prevention organization. We do things besides that, but for the most part, our mission is to end HIV in DC and have a very positive, affirming, healthy wellness lifestyle for all of the young people we serve. So part of what MTA does is we offer free STI and HIV testing through a drop-in center. Anybody, you never have to call and make an appointment. You can come right in, knock on the door, and we can get you in and out with an HIV rapid test in about 20 minutes. We also do have a mobile unit that goes to different events throughout the city, and also, you know, it can be anything from street events, like when Adams Morgan's Day happens, or 8th Street, those types of events, or very youth-focused events. We go to community centers, and we will test you through our mobile van. We do offer also free condoms. We have a drop-in youth center, which has a lot of after-school programs, including game nights and spoken word open mics that happen once a month. And our department is the capacity building department. We are facilitating trainings to providers like yourself on an array of topics that deal with both HIV prevention and also just how to work with youth. So today we'll be discussing working with LGBTQ youth in healthcare. So some of the objectives that we'll be going over today. First, we'll be dispelling myths about LGBTQ youth, so culture and community norms. We'll be discussing vulnerabilities that place LGBTQ youth at higher risk for potential negative health outcomes. We'll be enhancing interactions and positive outcomes with LGBTQ youth in a healthcare setting, so we'll be talking about some best practices for that. And finally, understanding the importance of delivering respectful and culturally responsive treatment to our LGBTQ clients, members, patients, employees, friends, family, etc. So we're going to start off with just a basic difference between gender and sex. Who wants to shout out the difference between gender and sex?
Gender is how you identify or what you would identify with. Sex is what you were genetically born with.
Exactly. Gender is cultural, sex is biological. So natal sex and anatomy deals with male and female. So that is biological characteristics that make up whether you're male or female and put you on a binary, basically. We also, intersex would fall within that category. We tend to not like putting I as in intersex on the LGBTQ spectrum because LGBTQ, lesbian, gay, bisexual, transgender, and queer questioning is all about personal choice and identity, versus intersex is actually dealing with anatomy in biology. So natal sex, can you press it again, I wonder? It's all supposed to come up on the other end, so I'm sure we could all figure that out. But natal sex is male and female. That's dealing with anatomical characteristics such as penises, scrotums, internal sex organs, external sex organs. And then later, secondary characteristics like what happens with puberty, facial hair, breasts in women, etc. So gender identity. Who wants to shout out what they think gender identity is then, within that context?
How you identify yourself?
Mm-hmm. Yes, gender identity is also based on this male-female binary for the most part. We are trying to push away from just male versus female, but gender identity is your internal sense of self. So some people conform to what gender is prescribed for them based on how they were born. Other people don't necessarily have to. So then gender expression is how you express your gender. That can also conform, that doesn't necessarily have to. I can be an effeminate male, effeminate meaning having more feminine characteristics, but that has nothing to do with my sexual orientation. It's specifically just how I'm expressing whatever gender I choose. Gender identity deals with your name, it deals with your pronouns. How do I want you to refer to me? My name is Eliza. I would like to be referred to as she, her, or hers. So it's very important, and we'll get into this later, to make sure with your clients that you're not only asking what their name is, and for most of you what their biological sex is, but also how they want to be referred in their pronouns. So gender expression deals with a feminine to masculine scale, what society thinks of as the most extreme representation of femininity versus the most extreme representation of masculinity, and most people fall somewhere in between. We do trainings with youth a lot on gender expression and gender identity, and it's very interesting. We'll give them paper images of different celebrities, and we have them go up and put them on a scale and try and basically determine, based on these pictures, why they're putting them on this scale from masculine to feminine. And every single training is different. Sometimes we have the most feminine-looking people on the masculine side of things because they're pointing out that they know that this person is transgender. Other times, the most feminine-looking people who are transgender are on the other side of femininity. So it's very interesting. Also, you know, based on the celebrities, Prince falls somewhere in the middle, so does Michael Jackson. So then we have sexual orientation, and it's very important to distinguish sexual orientation from gender expression, gender identity, because sexual orientation has nothing to do with it. It can align. Some people choose to express their gender in a way that they're also trying to express their sexual orientation. But for the most part, we have to think of them as completely independent concepts that really don't have anything to do with each other unless the person wants them to. Does that make sense to everyone? Any questions on the difference between sex, gender, and sexual orientation? How many people have heard of Kinsey? Yeah. So for those of you who are not familiar with Kinsey, Alfred Kinsey was a biologist at Indiana University who published a lot of, I'm from IU, so Hoosiers, published a lot of studies on sexual histories among men and women, and one of the biggest findings that he had was this development of a Kinsey scale between 0 and 6, 0 being exclusively heterosexual and 6 being exclusively homosexual. And he found that a lot of people, based on their sexual experiences and based on who they were attracted to, fell somewhere in the middle. Oh, good, Seema.
Oh, it came after.
So myths and misunderstandings. These are some common general misunderstandings that we hear a lot with both youth and with adults about the LGBTQ community. Number one, it's just a phase. Who here wants to take a stab at example, something you've heard before where this specific myth or misunderstanding has come up? No one? Okay. How about when a youth is very young, maybe 10 years old, and comes out as gay, and parents are whispering behind the back, "Oh, it's fine. Just let him do what he wants because it's just a phase. He'll come out of it later." Right? We hear that a lot. We also see people who they're in the process of questioning, and so that's just a phase as well. So this is one of the biggest myths, and it can be very hurtful for youth who very much are identifying in a way and are not being taken seriously for it. It doesn't really exist. That's lending itself also to it just being a phase. LGBTQ people are promiscuous. I hear this one a lot in our trainings, especially with young people, specifically bisexual or transgender people. So bisexual, we get the main comment we'll always get is, oh, well, you know, on Friday night, the girl's going to hook up with a guy, and then on Saturday night, he's going to hook up with a girl. And that's a common myth that we're constantly having to dispel, simply because, you know, there are many people who identify as bisexual throughout their entire lifetime and have only been with one partner or in a monogamous relationship. And it's really challenging for some people to wrap their heads around, if you're bisexual, why are you in a relationship with just one person, even if it is monogamous? But there are people who identify that way, and we have to just keep going back to remembering that if you are bisexual, that's your own personal identity, and nobody should tell you otherwise. Bisexual and or transgender people are really gay but unwilling to acknowledge it yet. That's kind of segueing into the more promiscuous one. You know, we hear a lot of times we attribute, if you're questioning, that means you're bi, that means that eventually you will choose one or the other, and you'll stick with it. And so, especially also with transgender people, we hear that sometimes as well, which can be very shocking because transgender, like we said from the beginning, there's a separation between gender identity and sexual orientation, and people really like to push those two together when it comes to transgender people. Only women are really bisexual. That we hear often, especially with males who say, you know, if a female hooks up with another female, then maybe she's bisexual, it's her choice. But if a guy is dating exclusively women and has one sexual encounter with a guy, he's automatically gay for life, no matter what. So that's something that we're constantly having to dispel, and you know, you just start to, especially working in these trainings with youth, you just start to kind of probe questions and give different examples and see how they start to wrap their heads around it, because that's a very ingrained myth in a lot of people's minds. And finally, transgender people aren't real men or women. This one really bothers me personally. It's very interesting to hear where people are coming from of what makes a real man a man and what makes a real woman a woman. And though many people have their ideas of extreme masculinity and extreme femininity as real men and real women, they talk about gender roles a lot, and then when it comes to discussing transgender people, they start talking about, well, it's not really about the gender roles, it's more about the anatomy. And because you were born with a penis and now you have a vagina, you're never going to be a real woman. And so that's a really tough myth and misunderstanding to have to dispel, but it's worth always having a conversation with youth about if you're in that situation. Any questions on myths and misunderstandings?
I'm quiet.
Yeah. Any comments?
I find that I think there are lots of cultural implications for only women are really bisexual, but also that the LGBTQ people are promiscuous, that people associate that actual act of sex with the expression and identity and gender identification. And I think that is, because we work in school-based centers, and so I've been having some conversations about that quite a bit lately. Would it be accurate to go down that path on some level?
I think it's incredibly helpful to do that. You're talking about actually having conversations with your clients about that.
Right. Well, like you brought up the man who had sex with a man, and then we just automatically categorized him as gay. Whereas, so we're separating, and he says, I'm not gay. You're not gay. He said you're not. But that one particular act of sex is what puts him in that category, which we need to kind of separate those out.
Exactly. Separation is very key. We've had a lot of trainings where participants have asked very personal questions about, I had this sexual encounter with this person, does that mean that I'm this? And it's really important to really emphasize that when it comes to yourself, it's your own choice. So if you choose that you want your past experience, and especially past sexual activity, to dictate how you orient yourself and how you identify, then that's your choice. But previous experiences do not determine what your sexual orientation is. And that, it's really hard. It's really hard to try and separate. Another way you can work with your clients is trying to reinforce that sexual orientation isn't just about sex.
Right.
It's also about your attraction to them spiritually, emotionally, romantically, physically, and sexually.
And one thing just to piggyback on that is, a lot of times we make assumptions that if someone automatically identifies as LGBTQ, that they're having sex. And all LGBTQ young people, they are embracing their identities or their sexual orientation, but they very well may not be sexually active. So we want to keep that in mind.
So, do you want to speak so we can?
Stand right here. I'm sure everyone can see me clearly. So, what puts LGBTQ at risk for negative health outcomes? So before I go into my spiel, most of you guys work with youth or young people. So what are some of the things that you're seeing or you feel may, particularly with LGBTQ young people, put them at risk for negative health outcomes? What are some of the disparities? Direct access, okay. What are some other things?
Stigma.
Okay, yeah. Anything else someone might want to talk about that they've experienced? Yes, ma'am.
Hey, it's assumptions, like if the parents are in the room and, like you say, an adolescent may not have, had a sexual experience but is wondering, and
exactly,
and the parents just assume
exactly
that their kid is ready. And how do you talk about that?
And
go ahead. We do this a lot. We are raised in very heteronormative societies. No matter how much your personal parent is willing to embrace other options besides heteronormativity, it's always challenging to express to other people how you're feeling. So we'll go into that.
Yeah. So, and again, to piggyback off of what you were saying, I was going to say that that's a big factor with young LGBTQ folks. Definitely youth have decided to come out LGBTQ younger than ever before. And so we know that homophobia and stigma still exists. And so when these young people feel alienated from their families, their peers, it causes many different effects on that young people, particularly in their struggle with being able to fit in with what society says is normal versus what society says is not normal. So family rejection is one of the biggest pieces to young people actually ending up in worse sections of disparities than originally. Like, there are LGBTQ young people that are great with their families, they're in environments that are supportive of them. And so, you know, as an adolescent, they are growing into their adulthood and into their being, knowing what it feels like to be supported. Where on the flip side, you know, there are those young people, and I always want to reiterate that with the social stigma that comes with LGBTQ youth, there is a broader disparity with LGBTQ youth of color. The class of youth that there's really not research done to really find out about the enormity of the disparities that LGBTQ youth go through who are of color, and knowing that because of socioeconomic stance, you know, poverty, you know, where they live, the culture that those individuals, so they have to, you know, deal with a myriad of different aspects to not only being who they are, but they have to deal with their race, their age, where they live, you know, how much money they have, or their family has. Like, there's so many things that they have to, you know, kind of figure out which one are they going to be the most committed to. So with rejection, that can lead to housing instability. So we know that a lot of young people sometimes are rejected and get put out of their home. And so where are they going to go? We were talking earlier about where does the young person who their mom or dad puts them out at 16 years old? Well, technically, by law, the family should not do that. But in the East Vet, that the family just is refusing to take this child back, then what happens? Then the child gets put into the system, and then they have another piece to deal with even more rejection and abandonment issues, and then being brought into the system within that way. Isolation, friends, dating, peers, basically really reiterating the fear. You know, there are lots of young people who, they don't go to school, they don't want to do anything with their lives because the fear of dealing with the outside world, the stigma that they're going to receive. There's a clinical term for it, agoraphobia, where you just don't want it, just the thought of having to look the public in their face, you know, can be a very frightening thing. So fear of physical attacks, including bullying and harassment, LGBTQ youth are far more greater to be attacked maybe on the streets, in schools. Definitely here in DC, with DCPS, we do lots of training with teachers and faculty and staff as it relates to bullying and harassment policies that are already implemented and have been in place for quite some time. But these policies are not being enforced. People are seeing these interjections of harassment and bullying taking place, and they're not documenting it. They're not intervening in these situations, so the young person doesn't feel supported. So why go back to school the next day if you feel like you're going to keep going through this repeated cycle? So those are just a few of the social stigmas that we talked about the homophobia within their race or ethnic group. So we know through research that the African American culture is not quite as accepting and supportive, say, as the Caucasian culture, because in the African American culture there is no such thing as being gay. So if you're black and gay, you're really not a part of the community. And that still exists today, unfortunately. Racism within the predominantly white LGBT community, so that's another unfortunate stance that we look at, that we still pretty much deal with today. And so, you know, dealing with being able to want to be a part of your culture and race, but feeling like it's more important for you to be yourself and be who you are. And being able to connect with other races that are just like you. Ageism, that's within society as a whole. It took me a very long time to feel like I could, when I was a case manager for youth, when I worked at Smile, you know, I really didn't think those young people would be able to teach me anything, but I learned a lot from the youth, from terminology to how to address certain issues, things that I would have never thought, that I would have been like, look, you're supposed to listen to Leandria, I'm your case manager, so on and so forth. It didn't work that way. You know, being able to know that youth also are very resilient individuals, LGBTQ youth. They come from all different backgrounds, all different religions. So, you know, you can learn so much if you take the time to listen as a provider. Are there any questions on any of what we've gone through thus far? Quiet group? All right, so mental health concerns. So with the things that we just talked about earlier, with the disparities that cause negative health outcomes, the mental health piece is the biggest piece of the pie. And I heard someone talk about access to services. That is the most minuscule service that is available and affordable to LGBTQ young people. I can look through the yellow pages all day or go online and look for mental health services for adolescents. And if there are services available for adolescents for therapy or mental health evaluation, it's going to cost like an arm and a leg if that person doesn't like have something. Most therapists don't even take insurance, so in their youth, they're probably not working, and we don't know what's going to happen with the support of their family to do this. So why is it that these young people can't get what they need to feel happy and whole and have a better health outcome? So these are some of the indicators of what happens when these issues are not addressed. So we know what happens with depression. We know about suicidal ideation, when you feel bad about your life and things that are going on. Body image issues, you know, in the LGBT culture and community, you know, you have to fit in, you have to sometimes look a certain way or be buffed or be beautiful or however it is. Every LGBTQ youth come in all sizes and shapes. So it might not be congruent with what mainstream LGBTQ folks say you're supposed to look like, which leads into tobacco and substance abuse. You know, it's a shame that these are the conduits that young people who identify as LGBTQ utilize as a coping mechanism. And usually the things that we see on this list does no good for the body at all. And are there any questions on what we just went through? Yes, ma'am.
I don't necessarily have a question, but I just think that puberty itself is such a trauma for a young person that might be questioning or be a female but identifying as a male or vice versa. And you get puberty is now you get rest and you have periods. And on the other side, if you're male and your voice changes, it just increases your risk of suicide.
Oh, yeah.
There are some programs that are treating those young people to sort of like delay the onset of puberty.
Yeah, there's medication.
There's
now to delay that.
I think you have to be I forgot the age range with which they are actually doing that to delay, and they're particularly for transgender individuals who, you know, they might be supported and they want to get on hormones or they want to, you know, but before you do that, there has to, you know, be this whole evaluation and knowing that this is still a young person. And as you said, with puberty and behavioral theory, just that whole thing of, you know, whatever age bracket they're in and really finding and knowing. We all, even as adults, still sometimes search to find out who we are, where we want to be in life, or if we're not. I just had a birthday recently, and I was like, oh my gosh, I'm just not where I'm supposed to be at the age that, like, I'm just, oh, what am I going to do next? Like, time is flying past. So, you know, with that, if we put our own selves in that sort of tenacity of knowing that, you know, life is forever changing. And so with a young person, it's double whammy for them because they have all of those various stripes against them already that we just talked about, the ageism, the racism, the homophobia, the stigma, all those various things. So I'm glad you brought that up. That's a great point. All right, Eliza.
Housing instability, and I just wanted to reiterate also, youth are all dealing with body image issues and low self-esteem. So, you know, this isn't just characteristic to LGBTQ youth, but we see that, like, not being able to be accepted as who they are is just a higher prevalence for feeling that way as well. But let's go into housing instability. We talked briefly about it. Housing instability and HIV/AIDS and STI transmission. So as we know, you know, this obviously is very general, and we don't want to make it seem like every single person who identifies as LGBTQ gets kicked out of the house and then they're at risk for HIV transmission. But as an organization, we really do focus on HIV transmission, STI transmission, and try and prevent new infections. And so we've kind of figured out, you know, through a series of circumstances why some LGBTQ youth are more at risk for new infection. So first and foremost, participating in risky sex, which includes survival sex. If somebody is kicked out of their home, especially if you are a young person, you probably don't have a job, or if you do have a job, it's probably minimum wage. And it's all of a sudden this HIV, STI transmission it doesn't become a priority for you. It's more important for you to find somewhere to eat or somewhere to sleep, something to eat, etc., especially, you know, depending on your circumstances. Maybe you don't have a friend that you can stay with. Maybe you can only crash on a couch for a couple of days. So, you know, you run the risk of having to participate in survival sex, and condom negotiation goes out the window often. So that is something that can be a very unfortunate. Did you have a, yeah?
Today is the very first day that I've actually heard the phrase provocative sex, and I think when I'm thinking about teenagers, and I suppose I automatically go to, I'm thinking survival sex, so we're talking about resources, money, housing. The person who might be providing that wouldn't necessarily be another teenager, and being more of an adult, which makes me not think of the situation as survival sex, more of exploitation, statutory rape, things like that.
Yes.
So it's like survival sex is like.
Yeah, but you're also thinking of it from an advocacy standpoint versus if you put yourself in a youth perspective.
Yeah.
Exactly, they're doing this because they need a place to stay. And somebody approaches you who's older, who has a couch that you can stay on, who offers you a place to stay, something to eat, money to survive, and all of a sudden everything else goes out the window because that's what you need at that point in time. And it's a really unfortunate reality that we do see.
I mean, if we were if we were talking about in the context of like pimps and johns and things like this, would we still identify that phrase or that context around that phrase in the, you know, like if we were discussing with the teenager, that's how we would talk about it. It would be the best way to deal with that, or how do we? That's
yes and no. When it comes to human trafficking, anyone who is being sold for sex or they're being sold for something, which includes housing, money. If they're under 18, they're considered a trafficking case, right? But if you are being trafficked, that means that you have a pimp that you're reporting to, that you have your quota. So it's not, you are having sex for the money. So, you know, you can be recruited in through maybe survival sex means in the sense that the pimp recognizes a vulnerability and takes advantage of that and exploits you. And it is sexual exploitation, whether it's the John or the pimp. But it's not really survival sex because they're having sex to meet that quota by the end of the night. Yeah.
So I think, maybe some of the clinical correlates we're looking for are some of the wordings, and one of the phrases that I use and kind of gotten comfortable with is, have you found yourself trading sex for any favors, staying from home, things like that? They don't really think about it as selling, for sure, like prostitution, but, and I find that trading doesn't even sometimes cut it because they don't even think of it as trading. They're just like, well, this person's good to me, and I'm getting something out of it, and they're getting something out of it, and it's all good. But it puts them in a riskier behavior, especially because those people are usually more resourced and usually more older and things like that. So do you have any other phrases that we as clinicians could insert into our lexicon?
I mean, Nick, do you want to? Yeah.
I was going to say, I do HIV testing, so when we do a risk assessment, one of the questions we ask is, how do you exchange money or drugs for sex? That's usually pretty straightforward.
Or even more vague than that, have you ever had sex for money, housing, food, clothing, shelter? Just, I think a lot on the risk assessment, they'll say exchange sex for money or drugs, but you can continue to elaborate on that as you see fit, right? I mean, there's a myriad of different reasons why someone would need to have survival sex, as we put it. So, yeah, just continuing on that, starting to list them and see if something hits home. Yeah.
I do think that the discussion is important to have just among us as colleagues in the system, of broadening our ideas of prostitution, getting away from the idea there's stuff that you return to, or that's not the only way to be used for sex. Whether you have that older friend that you've known for 15 years, and now there's this special relationship, and they provide you housing, and times are tough, they can be there. It's just a good idea to keep in mind a bigger picture, how sex can be coerced if you don't care.
Sure, and if you're under 18, I just want to reiterate that it is considered trafficking, but there are people who are under 18 who are having sex because they're participating in sex work.
Right.
That's just what their trade is.
And most of them, if they are participating, they don't look at it as sex work. It's even exchange. It's like, no, because they're not standing on a corner, or they're not online, or whatever the situation might be. So like you said, it's a good friend that I met, they're older, they're wiser, they're showing me the way, and they give me money, and I have sex with them. That does not make them a prostitute. That does not say they feel like they're being trafficked.
If they're under 18, are we required to report?
So if you're under 18, I'm sure all of you know about mandated reporting.
You guys do that too?
We would have to report if we encountered a young person who was under the age of 18 and reported that, based on the information that they would give us, within that, then we would have to let them know that we are mandated reporters and that we're not breaking their trust or confidence, but what is happening is against the law.
But what happens to that trust and confidence?
So it becomes a very complicated process. So technically, depending on what the situation is, like a very simple situation would be, say, a client comes in and they've been physically hurt, right? So you would have to call the police, who would then contact CFSA, who would then assign a case manager to it, who would then circle back with you or your supervisor, and then start to help negotiate what's going on with the client, whether you need to get the parents involved, whether the parents are the issue. So it's a very, step-by-step process, but if you were to let that slide, then it would be on you. So it's illegal.
Like I had a client similar but they came back and told me that they saw, so they were underage, and they went to a program, and the person in the program propositioned the young person for sex. The young person agreed. So when the young person agreed, they came in like the next day or something and said they saw this person on a magazine and they were HIV positive and that they hadn't had protected sex with this person, but they didn't want to get the person who was running the group in trouble and so on and so forth. So they come in, they get tested. I'm like telling this individual, well, if I test you, you wouldn't know today anyway, because we know the window period of that. But I had to like literally sit down and explain to this person like what that was going to mean for them in the future. What if they came back positive? What if this has happened to other young people? You would not be like the first victim of this if something like this has happened before. And that I am a youth worker, and it is in my best interest to adhere to the safety of the young person that is in my care at that time. And I think they take it when you sort of give them that understanding that you're not doing that to betray the young person or tell on them, but you're doing it for their future and safety. And that's what we are mandated to do. This is our job. This is what we have to do. And to let that young person walk out the door because you want to uphold their confidence and trust in you, and then something disastrous happens, then what happens with your agency and you as an individual? Like, where's your integrity with that? So we try very much not to let any of those youth slip out of the door, and very much try to explain to them that we're not betraying them as youth service providers, that all of us have to do that. Yeah.
Is it fair, I mean, is it a fair, well, I guess no blanket statement is, but that many homeless youth who are more likely to be LGBT just due to the being kicked out of the homes due to stigmatization are tricking for money? Are homelessness and adolescents commonly connected with that?
I don't want to say yes or no because I don't have any statistics in mind, but
Anecdotally.
Yeah, anecdotally, it has some of those nuances.
Yeah. Because there just aren't that many sources of income.
Exactly. And so, and again, a lot of young people make connections with older cliques. I can speak very much for the African American LGBT community. What they do, they have a sector of houses that they connect with that are considered, you know, their families, their brothers, their sisters. They're not biologically related, but they all like come together as a group. They get housing, they live together, whatever. They participate in these, they are like competitions, so to speak.
they can almost become gangs in a sense.
In a sense, they can become that way. But that's the way they like all connect and just like get together and formulate these houses. And they have these balls that they go to, and they can win money. They can win hundreds of dollars to look a certain way or walk down the runway or whatever the category is suggesting, and you can pull that category off. You can win trophies and money for doing that. And usually that causes rivalry with the other houses because everyone thinks they were the best one, and so then they're fighting and trying to take, like, it's a big mess. But that's what they're kind of utilizing now as a mechanism for, yeah.
Go ahead. Well, I'll just summarize the rest of this really quickly because we're running out of time. So, you know, another way you can lead to HIV transmission is through back alley procedures. If you're trying to transition, it's very expensive. You know, sharing needles for injecting steroids and hormones and any type of, you know, like silicone, things like that, that can be a high-risk transmission rate. Also, just access. Because they're young, they're on their parents' insurance, we would hope, or, you know, they don't have a lot of money, so getting treatment for STIs, for HIV, for any type of transitioning surgeries, medications, that can be very expensive. So there's a lot of lack of access to health care and money for the medications, including HIV medication, STI treatment medication. And then finally, you know, because if they are homeless, they're not going to have a good place to store their medications and store their treatment or be able to, you know, take them at a consistent schedule, which is, especially when we're talking about HIV, incredibly important that you're taking your medication on time, even more important than, say, birth control from trying to get pregnant, right? So, you know, it's just a lack of storage and comfortable area to take it. And we can talk, if you guys have more questions, we can talk on the break. So best practices, let's go, best practices for working with LGBTQ youth as you're a provider, which is what you all are. So addressing the client, very simple. Like we said before, you know, maybe their name says one thing, but ask them, how do you want me to call you today? We have clients that come into MTA on one day they're one name, and on the other day they come in and they're like, don't call me that anymore. That was so last week. Call me this new name now. And so constantly just staying updated with what your client wants to be called. Also, more importantly, what pronouns they're going by. It is completely valid to ask somebody, you know, how do you want me to refer to you? Like, what are your pronouns? Especially if you notice that somebody may be confused about transitioning, they appreciate you asking instead of you just, if you see a male dressing very feminine, to automatically still call him a he if maybe he wants to start to be referred to as she, or a neutral pronoun or something of that nature. And yeah, please just ask. Be knowledgeable about transgender issues and about LGBTQ issues, just so you, I mean, this is pretty clear, that's why you guys are here today. So just continuing to stay updated on latest research, latest nuances, especially if you're working with youth, just latest youth culture, like Leandra was discussing before with the houses and ball culture and things like that. It's helpful when you start to understand where your client is really coming from, what they're doing in their spare time. It's easier to relate to a client that way. Focus on care, not curiosity. That's incredibly important. If you're supposed to ask what type of sexual activity they're engaging in, that's one thing. If you're supposed to ask what their genitals look like, that's one thing. But don't ask if it's not within your intake forms and necessary. And disclosure, the same confidentiality policies will apply if somebody comes out to you, whether they're coming out of their sexual orientation or telling you that they are in the process of transitioning or interested in transitioning, maintaining that confidentiality, because you don't know who else that they've come out to. Maybe their parents know, maybe they don't know, maybe, you know, a myriad of different people at this point. And finally, don't interview with a parent in the room. I think you said it before, possibly, or somebody said it before, about they may not have, you know, discussed all of this with their parents yet. They may be interested in getting more information from you as a confidant. Don't assume their name or their pronoun. Don't assume their gender identity and their expression correlates. Additionally, don't assume that their orientation correlates with any of those. Confidentiality, I don't want to reiterate that again. Don't dismiss the parents as a resource of support. Just because they're coming out to you and they haven't maybe disclosed to their parents yet doesn't mean that they're just trying to work up the nerves to disclose to their parents. And you don't really know what the home life looks like at all. So don't dismiss it as a phase, and don't refer for reparative therapy, especially if they're under 18. You want to make sure that parents are on board. I think at 16, you can start receiving treatment if you're interested in transitioning, but you have to have parental consent for that. So.
And don't assume that all LGBTQ youth are struggling. I just want to reiterate that again, because all of them are. But most of the time, the perception is, oh, poor thing, and we don't want to make that assumption.
Where do you refer for someone who's 16?
For which type of reparative therapy? What you would know is better.
For my clients, I would bring them here to children. Angela Wilbon, I don't know if any of you. She's not here anymore? Oh, wow. So I wouldn't really know who would.
Donna Marshall. I think she goes to Donna Marshall.
Oh, okay, okay.
Same department.
What's the name of the department?
It's the Department of Adolescent Medicine, and she's a psychologist, so you can work with our psychologist. And for our transgendered youth, we also work with the endocrinology department, so we have sort of a multidisciplinary team that works on that, but generally you can start in the adolescent medicine department. If there's overlap as well with HIV, we have convergent clinics through the adolescent department for our HIV youth. So we work with other institutions around the city as well.
And also, I was going to say, Dr. Thomas McLaughlin at Whitman Walker Health would also, if not being able to do that directly, would have great resources on where to refer. Yes?
Can I just ask you to clarify, maybe totally have to clarify reparative therapy? I just think reparative therapy is a very, I consider negative. Trying to convince somebody that they're not in a program. Change something that, am I right about that or not?
My impression of reparative therapy, I mean, I don't have a medical background, so my impression of reparative therapy are two separate entities in a way. Like, first entity is more mental health stuff, like trying to fix your mind, like with like gender identity disorder, now changed to gender dysphoria. And then on the other hand, and please correct me if I'm wrong, it's more about, you know, like for patients who are interested in transitioning, don't refer them to any type of like transitioning resources until they're 100% on board with what they're trying to do and the parents are on board if they're under 18.
So
yeah.
Maybe don't refer for gender reassignment.
You can, so sort of like a catch-22, because if you can't even get gender reassignment surgery unless you've had the therapeutic piece of all of that.
And you can't get it covered unless you identify as,
Say that again.
I don't think it was reparative therapy.
Oh, no, that has nothing to do with gender reassignment surgery. If that were, like, this would be like trying to, that particular style of therapy would be trying to convince that person not to transition.
I think that's what
rather so than
negative. However,
I'll send them to some camp.
Okay, good. That's what I
to
right.
Against
Exactly.
And that's what you meant by this phrase.
we meant both.
Oh, you meant
yeah, we meant both, like, you know, not sending them to like something to change their mind, but also
but sending them
too early for like any type of reassignment stuff. Yeah.
So the resources that I gave you are people who are going to help them get comprehensive mental health therapy, not to, you know, they might have referral resources for other repetitive therapy services, but in the mainstream, those people that we work with and that are here at Children's are helping those young people figure out what's going on. If they get their diagnosis and they can move forward, see the endocrinologist, get their hormones, do whatever it is that they need to do. And so now it's going to be difficult for anyone to denounce that with the new healthcare trans law that has been implemented in the District of Columbia. So trans healthcare will become a mainstream conduit to going to the doctors and getting the healthcare that's needed. So I think we're out of time.
Our email addresses and all that fun stuff is there. If you have any other questions, please feel free to email us. Sorry we got a little bit rushed at the end. But I think it was important to have that conversation we were having about survival. Yeah. So thank you all.
Thank
Hope
you.
you have a great rest of the conference.
And the evaluations, if you've got them completed, you're welcome to put them in the bin, but we also will collect them downstairs.
Yeah, our evaluations, though, we would appreciate you.
Not all of them. I'll send you all of them. Oh, yeah. Don't worry about that. I'm trustworthy. Yeah. So male reproductive health is downstairs in the auditorium. And we'll be swapping positions.
Imperative was a word that we were told to use yesterday. Thank you.
So
Imperative was a word that we were asked to use. Oh, okay. Part of. That's why when you asked them.
I got to
Oh, yeah.
Right. I worked with the youth, but I mean, it's really, when you know, from my background, it's always
It's such a negative.
You were here?
It's incredibly negative. Unfortunately, so now you can get your sexual reassignment surgery covered, but you still have to be diagnosed as gender dysphoric. So it's still, like, I mean, that was happening beforehand, but you would have to pay out of pocket no matter what. So, I mean, it's unfortunate that mental health counselors are still being
Something wrong with your mind.
Yeah. Yeah, I mean, you have to keep in mind that there are a lot of ways for if you are interested, children are interested in transitioning, there are still laws to adhere to in terms of when they can receive those medical services, in terms of like reassignment surgeries and things like that. So.
There was somebody with children that in the high school wanted to start talking about surgery. And I called and told the guys that was a psychiatrist and he and somebody.
Here?
Yeah.
I think I know who you're talking about. Yeah.
It's really helpful. But yeah, it's
Yeah.
just about counsel goes along with getting them prepared for what it will mean to them.
Right, right.
It's really important.
Yeah. Okay. Well, thanks for the question. Yes, thank you.
So because we're a little bit of pushing in, I think we're for the but just know your audience, right? It's a mix, but there's a lot of people listening. So I like take her cups and partner and give. Take her cups as you some of the use your pronouns. Not that use your pronouns, like make sure you like your how to use your pronouns. Really will have super practice. It's infusing them along the way. Exactly. And then when you hit the five, you just get the out because we're done. Which is handy. So I think you're
Hello.
how are you? I did well. I was at work because I'll be.
Well, this is not. Oh, yeah, no, this is. If you went through a second. Well, we're talking about LGBTQ science in general. It's going to cover similar stuff.
Were you not
We went to working with transgender youth and health. This is LGBTQ youth, so it'll have a larger scope. But you took so many of our trainings. I couldn't even remember. Yeah, I think you need to put up with me. That's no problem. No, I'll stay.
Are we already behind?
It has similar content, but it's not transgender youth. It's more about like not only it's more about like negative health outcomes that put LGBTQ more at risk.
Yeah. Perfect.
Good. Is that not? I think you need to leave one more.
All right, Tanner, you can facilitate this portion. Yeah. It's due to start at 3:30 or 3:15? To 4:15. 3:30 to 4.
3:30 to
4:15.
I will need water.
Yes, if I could get a water would be great.
I can fill this up right now because the bathroom's right here.
I'll look for another water.
All right, thanks.
Ready?
Yeah. I'm ready.
All right, so we're going to go ahead and get started. It's really hot in here, but they're watching the World Cup out there, so we'll try and play with the noise and see what works.
You want me to leave the garbage can in the door?
I feel like for now, is everybody hot? Good?
You're okay for now, you'll open it later.
Okay. All right. Good for now, and then once you're hot, just like do a little twirl, and then we'll know that that means hot. Okay. Great. So my name's Eliza Sarah-Capone. I'm the Capacity Building Coordinator at Metro Teenage, and you guys are here for working with LGBTQ youth in healthcare.
And I'm Leandria Gilliam. I'm the Capacity Building Training Manager. And so
how many people have heard of Metro Teenage before? A few. So where is everybody else coming from for the most part? Shout it out.
Where are we from?
Yeah, like, oh no, sorry, not.
what organizations are you
in? Georgetown? Okay.
Okay.
Silver Spring.
Community Health.
School-based health center.
Sorry?
Say that again.
School-based health center, cool adoption.
Cool.
Oh, yeah. Hey. I bet you look familiar, right? You want to?
Private practice? Okay.
Howard University.
Okay. So as most people focus more on clinical sides or working with young people, what are we? Health and education?
Consulting.
Okay. Great. So we'll try and give you a comprehensive look at both more clinical sides of things as well as just best practices for working with youth, no matter LGBTQ youth, no matter if you're in a healthcare setting or not. A lot of these best practices still apply to just interactions. So Metro Teenage, we are a community health organization based in Southeast DC. Our mission is to end HIV. So we are an HIV prevention organization that focuses on young people ages 13 to 24. We have free HIV, STI, pregnancy testing, drop-in hours. You never have to make an appointment. You just knock on the door, you come in, and we offer a rapid test, either the Clearview, which is the finger prick, or the OraQuick if people are scared of blood, and you'll get your results back in 20 minutes. If you were to test positive, especially for HIV, we would immediately connect you to a care advocate and start taking you through the process of getting your confirmatory test, et cetera. Additionally, we offer free condoms to anyone who comes in. We have a drop-in youth center where we have different activities such as, Floetics Friday is our big last Friday of the month open mic spoken word night where people can come in and sign up, and we offer free testing there, lots of condom giveaways, and people are able to perform their own spoken word pieces. So we have a lot of drop-in activities of that nature. We do have a mobile unit that goes around and does HIV testing at different events throughout the community. And then we also have community and school-based trainings, which is our department. We are the capacity building department. We offer trainings to providers like yourself that gives you information on an array of topics that can deal with HIV prevention specifically, or just how to work with youth. So today we'll be talking about how to work with LGBTQ youth. So some of the objectives we're going to go over today, we're going to dispel myths and misunderstandings about the LGBTQ youth culture, community, population. We're going to discuss some vulnerabilities that put LGBTQ youth at risk for negative health outcomes. We'll be talking about how to enhance interactions and positive outcomes with LGBTQ youth in healthcare settings. And finally, we'll be discussing the importance of delivering respectful and culturally responsive treatment to our LGBTQ youth clients, members, patients, employees, friends, family, etc. So, gender versus sex. Who wants to shout out what they think the difference between gender and sex is?
Sex is a physiological concept, and gender is a cultural, self-identifying psychological concept.
Did you have something to add, Sheikh?
Gender is what you identify as.
Exactly. In short, sex is biological, gender is cultural. Sex, and we can go into, so there's natal sex or anatomy, and that is dealing with any type of biological makeup. That's your anatomy, that's your hormones. There's primary sex characteristics, which are identified between, you can keep going, male and female, and also intersex. That's internal and external sex organs. So when a baby is born, you see the penis, you pronounce it's a boy. That would be their sex. If their internal organs matched, would be male, right? So those are your primary sex characteristics. Your secondary sex characteristics are things that appear at puberty. So, you know, facial hair, breasts, in males, lower voices, and the Adam's apple. So that is sex. It's entirely made up of biological characteristics. Gender. So gender identity is your internal sense of self, right? It's how you identify. You could conform based on how society deems a male is supposed to act and a female is supposed to act, but you don't necessarily have to conform. Gender in itself is its own spectrum, from masculine to feminine. When we talk about gender and transgender, we talk about a scale of male to female that incorporates your own personal identity and then how you relay that to other people. So with gender identity, we're talking about, you know, what your name is, what your pronouns are. So female, I'm female, my name's Eliza, I go by she, her, and hers, right? Somebody else, I have a client who is male, he wants to be referred to as they, them, or theirs. So it's all about, that's your gender identity. It's about figuring out your pronouns and how they're feeling internally and how they're expressing that. So then we go into gender expression, which is how you're outwardly, how you're outwardly relaying your gender. So this often comes in, you know, what characteristics make up what we think the extreme version of masculinity is versus the extreme version of femininity. For instance, we do a training a lot with our young people where we give them images of celebrities and we give them the scale of feminine to masculine, and we say, put these pictures on a scale of what you think masculine and feminine is. So it's about stereotypes, it's about what culture deems as what the most masculine male looks like and the most feminine female looks like, but for the most part, people just fall very much in between. And you'd be really surprised to see, based on where people's mentalities are at, where they're putting these pictures of normal celebrities. Then we go into sexual orientation. And sexual orientation is who you are attracted to, both mentally, emotionally, spiritually, physically, romantically, and sexually. And it has nothing to do with gender at all. It can correlate, but we have to think of them as incredibly different concepts that are entirely independent of each other. And we tend to often merge things together and say, well, that male was born a male and is acting very feminine, so he must be gay. And he could be born a male. He could be expressing his gender in more of what society deems as a feminine expression, but he could be 100% attracted to females. And so we have to make sure that we're really maintaining that difference. Any questions about this? Any comments?
Another quiet group.
Okay. So, some myths and misunderstandings about LGBTQ youth. Number one, it's just a phase. How many people have heard somebody say that in passing about somebody else before? Raise your hand. Does anybody want to comment on, tell a specific example?
Well, I had a friend in high school, and he was very feminine. And they were all like, oh, it's just a phase, it's just a phase. And then he'll even say like, oh, you know, he didn't accept that, you know, he was gay. And at the end, like, when he went to like college, he like came out and it was good. But like everyone will say like, oh, you know, it's just a phase. Like it's kind of like even like his mom was very like strict. Then I have another friend who is now in college and his mom just found out he's gay, but she can't accept that. Like, she controls everything he does because he thinks it's a phase, and she thinks that because he has like friends that are gays and lesbians, that that's why he's gay. So it's been a really hard process for him because his mom cannot accept the fact that he's gay.
Exactly. So, you know, when it comes to sexual orientation and different cultures, everybody has their own stereotypes of what it means to be one orientation, one gender, one representation of something. And so it's very hard as a young person specifically to have to constantly trying to challenge that and have people just dismiss you as, oh, well, you're just in this like weird phase, this like weird questioning phase. You'll figure it out eventually. Yeah.
Sorry, I was going to give another example.
Sure.
I was going to bring up the controversial one recently with the young, self-identified as male, but born female. It was on the news. 5 or 6 year old child, and was saying that they identify themselves as being a male. However, they were born a female, and people were arguing that this is a phase. However, the parents allowed the child to be raised how they felt that they were as a male. That was a big controversial issue, which some would say, oh, was the child sort of a tomboy using the title, or, you know, is this a phase, or what's it? So I just do that.
Yeah, no, exactly. I think when we're dealing with youth, we work with youth, right? And so when you're dealing with people who are 18 and under, you start to really attribute that just a phase thing because you think to yourself, well, they're too young to really understand what any of this means. And it's very important as providers to be validating people's feelings, even if they do come up the next day and say, well, actually, you can call me this person now instead. Like, we have one client that comes in every once in a while, and every single time this person comes in, we call them by their name, and then many times we've been like, oh, actually, call me this person instead now. And so we started to just develop a process where it's like, okay, well, what should I call you today? You're dressing very so-and-so today. Is that your name today? And you just have to kind of go with that and know that maybe this isn't just a phase for this person, but it could be. And we're here to just validate them in that present state and help them figure out tools to navigate that for the future. Another myth and misunderstanding, it doesn't really exist. This is, I believe, more of what you're talking about, where we have, you know, you hear stories about somebody, especially a young person who identifies as gay, no matter if they're male or female, and the parents go, oh, well, let them get it out of their system now, because they'll eventually, you know, they'll get married and have babies later. This isn't really existing. So, you know, those two very much are very similar. LGBTQ people are promiscuous. This specifically focuses more on people who identify as bisexual or transgender. We hear this so much in all of our trainings that if you're bisexual, you will go out, if you're a female and you're bisexual, you'll go out and on Friday night you'll have sex with a guy, and then on Saturday night you'll have sex with a woman, and then next weekend, you know, maybe you'll have sex all together, and that's acceptable and that's what's expected of you if you're bisexual, right? No. Yes.
I'd like to question that as being a myth for gay men, because, you know, from experience, I can tell you that gay men have many more opportunities than straight men to have sex with another partner. And so I'm wondering if there's really data that shows that this is a myth, that's the reality. Because my experience is that gay men have many more opportunities
is a culture.
But is there data that says that it's not true, or is that just what's politically correct and what HRC wants us to do?
There is obviously going to be cultures where there are groups of people who are being very active and exploring a lot of different partners. I mean, it's very known within the gay community, considering the AIDS epidemic when it hit in 1980, and that was considered the gay disease in the beginning. You know, that became very characteristic of, well, all gay men are going out and sleeping at these like sex parties, and their HIV's running rampant against them. So, you know, that.
Sorry, the world top is
yeah. That there's obviously truth to some of that, obviously, but you know, because stereotypes are created for a reason. But at the same time, we can't stand here and tell you that every single person who is gay is going to go out and have sex with a lot of people.
Maybe much more of a myth is at all LGBT people, because I think in general there is something, but not everybody, and that's a myth.
Yes, yes,
everybody.
That is a myth. But
I think that aligns with the LGBT community as a whole, and we talked about that earlier, some, not all, because people make an assumption that everyone is the same. Same thing with transgender. That's an umbrella term. Every trans person is not the same. So behavior and identity are two different things. So,
also, we have to stop to recognize that, you know, when it comes to sexual orientation, it's not always just correlated with sexual activity. And that's where some people have a lot of trouble. You know, just because you identify as gay doesn't mean that you'll ever have a sexual experience where you have slept with somebody of the same sex, right? So, like, oftentimes when we think about sexual orientation, we try and immediately correlate it and direct it to, well, what type of sexual activity have you had? And that can have nothing to do with how somebody is identifying.
So you're saying, well, using those terminologies should only be the person defining it for themselves versus somebody else.
Exactly. If somebody wants to choose to define their past experiences on how they feel, then that's their prerogative. But the way that we should be looking at sexual orientation is about how they're personally feeling and who they are attracted to in that array of reasons, not just sexually attracted to, right? Does that make sense?
You can define yourself, however, you see what I'm saying? Like,
theoretically, yeah.
Theoretically, it doesn't matter those criteria. You can choose how to define yourself. Period.
Yeah, I mean, you could get married to a woman and have children with that woman, but have really strong emotional connections with men and feel like your feelings are more aligned that you're bisexual, right? Does that make sense to everyone? Yeah? And that lends back into promiscuity, is that, you know, we're constantly connecting the two, and so we assume that people who are bisexual are going out and just, they're in their questioning phase, and they're just experimenting, and they're doing all of these sexual encounters to try and figure out who they are. Bisexual and transgender people are really gay but unwilling to acknowledge it yet. That, I mean, we've been discussing this the whole time, so I don't want to be too repetitive, but, you know, when it comes to transgender people, we've heard of many cases where you're identifying as something else, so you start expressing that gender, right? If I'm born a man and I start expressing more female qualities, then really I'm gay because a feminine male is gay. But transgender has nothing to do with sexual orientation unless the person chooses that it should. Only women are really bisexual. How many people have heard somebody say this phrase before? If a woman sleeps with a woman and another man, then she's bisexual. But if a guy has sex with women his entire life and one sexual encounter with a male, he's gay. How many people have heard something similar to that before? We hear that a lot with our youth. We do a whole training where we try and break that down for them because in their minds, one sexual encounter with somebody of the same sex for men makes you gay. No matter if it was when you were 12, 14 years old, and now you're in your 50s, well, people are still remembering that one thing. And finally, transgender people aren't real men or real women. It's very challenging. This stereotype is very challenging to me because when we work with youth, we ask them what it means to be a masculine male and a feminine female. Like, what does it mean to be a man? What does it mean to be a woman? How do you act like a man and a woman? And we always get responses on gender roles and expression. And then as soon as we try and bring into, into the conversation about somebody who has transitioned, they go, oh, no, they're never going to be a real man or a real woman because they don't have the anatomy to match. And so when we're talking about stereotypes and what it means to be somebody real, people tend to want to bring into the conversation biology just with when we bring in transgender, but for the most part, any other quality is incredibly cultural. So just working to dispel that is really important as well.
All right. She never came back with water.
No, she Oh.
For me.
Oh.
All right, so LGBTQ vulnerabilities and health. So I'm going to throw a question out that's up on the screen. What puts LGBTQ youth at risk for negative health outcomes? For those of you that are working. Oh.
Thank you so much.
For those of you that may work with LGBTQ youth, what are some of the things that you might preclude would cause negative health outcomes for LGBTQ youth? Yes, sir.
I would say the main risk is really the projection or bullying that leads to depression and suicide. I think that's the largest risk comparative to non-LGBT.
Any other things that people?
Not getting access.
Okay, we can start. Go ahead.
Like not getting access to care because they think they're going to judge them.
Okay, that's a great one.
Maybe lack of a support network.
Exactly. I saw your hand.
Similarly, like homelessness, so that is like the family is unsupportive of their lifestyle choices and being kicked out of a home and not being able to.
Exactly. So we know that LGBTQ youth commonly experience harassment and bullying and all the list of things that you guys have just listed. And so with that feeling of alienation from their peers, their family, youth environments that are specifically designed for them, consequently, it's striking, but it can cause a long-lasting effect on that youth individual. And so, people like us who get the opportunity to work with youth, we have that real opportunity, we have the real responsibility to address these issues and the needs of LGBTQ youth. So these are some of the things that we talk about as far as social stigma. And so with the rejection of family and friends, which I don't want to be redundant either, that definitely can cause other disparities to take place. Survival sex, different nuances, housing instability, not having a place to go. And we know that young people, particularly under the age of 18, there are no shelters, there's no place that those young people could go if they got put out of their homes and be able to find housing. So that definitely leads to social isolation with friends, dating, peers. So basically knowing that the stigma, the homophobia, the rejection, all of that stuff just commingles and really causes fear and just depression, as you said. There's a whole list of that on the next slide. But just to talk about with all of the social stigma, I like to reiterate that that stigma also is very more prominent in LGBTQ youth of color. And so that's a population of young people that have it just a little bit harder than the average LGBTQ youth, because they have a congruency, I don't know what happened to my slides, of disparities that include far more than isolation or rejection or stigma. We're talking about racism, ageism, homophobia, you know, all these different choices that that African American or person of color has to deal with in deciding which ethnicity or what, you know, who am I going to stand by, or am I going to stand by in embracing who I am and my identity. Fear of physical attacks, we talked about the bullying and harassment, as well as the homophobia, even within their own racial group. So we talk about the youth of color, and we talk about a community that says, well, if you're an African American youth and you're gay, you're no longer a part of the community, because there are no LGBTQ African American people as far, you know, as society or the culture will think of itself within that norm. As well as racism within a predominantly white LGBT community. We know that LGBTQ youth of color deal with a myriad of socioeconomic stances that don't allow them to have access to various services that they would be able to receive, as well as living in poverty. You know, sometimes they may have to drop out of school to work, to support other family. You know, it's, again, there are so many things that can come with that. And so with a predominantly white LGBT community, there are more resources, more services, more things that are going to be available to those individuals that are not available to African American young people. Ageism within a society as a whole, so that exists throughout. I know in the past I had been guilty of that, feeling like young people can't really teach you anything, but young people are very resilient individuals. They come from different backgrounds. They have different knowledge base about things, and I'm like my iPhone, they keep me updated. So, you know, it's better to be able to know what's going on in the world of a young person, so that gives you the knowledge base to better be able to serve them. So as you guys were throwing out a list of disparities, depression is a huge one. Mental health concerns as a whole. And the prior training that we had with the other folks that were attending, and one of the concerns that I have as far as mental health for youth is that it's a very minuscule industry. And there are not many providers that are taking on mental health services for young people, particularly young people that are dealing with identity, sexual orientation issues. We're not finding a lot of that. And if there are those individuals that are out there, they're $1 million, and young people wouldn't be able to afford it, especially since most mental health physicians and clinicians don't take medical insurance. So then we deal with suicide. Suicidal ideation is a chronic problem down to young people actually committing suicide because they feel like they just fit nowhere on the spectrum, and so many social norms are bombarding them with how they're told they are to be rather than who they can be on their own accord, and really being able to be confident and live in that. Body image issues, I'm glad you pulled me up on that, Eliza, because I think all of us deal with that in some form or the other. But generally in the LGBT community, there's a culture you know, you got to look a certain way. Most LGBTQ people are beautiful and whatever. But those things that makes individuals feel like they're still not fitting in within their own community because they're not connected body-wise or image-wise, that says they have a sense of belonging. Tobacco is not on here, but tobacco and substance abuse, alcohol, all of that good stuff. That's, oh, thank you. I got one prior.
It's cold.
This is cold, so thank you. I have plenty of water now. So substance abuse, tobacco use, like all of these are indicators of when you're not being able to get the necessary treatment and therapy or someone to talk to if you don't have a support system. If there's no one in place, if you can't go to a service provider and not feel that that service provider is trusting, they're not going to judge you, you know, and as service providers, as I said before, we have the opportunity and also we have the responsibility to do the research, find out what's going on, be that listening ear. And if we don't know, ask the young people because they will be glad to tell you. So I can drink some water now.
I'll go over housing instability. So we talk about, so we're an HIV-focused organization, obviously, so we're always trying to relate it back to how people are at risk for HIV transmission or new infection. And when we're talking about youth, you know, Leandria mentioned before how youth can easily be put out of their homes. We hear it all the time. As soon as they come out to their parents, they're kicked out of the house, whether it's for a night or whether it's for a longer period of time, which then can lead to some risky behaviors. I want to reiterate right off the bat that this is not every single person who identified as LGBTQ's experience, but this is what some people may go through if they've been kicked out of a house. So the first one is, you know, participating in risky sex, including survival sex. We had a big conversation last training about what survival sex actually entails. Who wants to take a stab at it if they've heard it before or hasn't?
Who's heard of survival sex before? It's pretty limited.
Like changing sex for food?
Exactly, exchanging sex for something. So when a young person or when somebody is kicked out of their home, the first thing that most people are going to prioritize is where am I going to stay, how am I going to eat, right? It's your basic survival instincts. And so when it comes to survival sex, that becomes something that, you know, occurs a lot. When somebody is looking for housing, they will exchange sex for a place to eat, for something to eat, for a place to stay, for a little bit of money, right, so they can go and get something else to eat. So that is a big issue that we see with some youth. And when it comes to survival sex, your priorities are your survival instincts, and they're not necessarily condom negotiation or making sure that you're protecting yourself during not only just condom but any type of sexual activity. So we see that this becomes a higher rate of HIV transmission. Additionally, if you are participating in any sex work, whether it's survival sex or you are just a sex worker, there is a fear of receiving any type of medical services because you think that what you're doing is stigmatized. So, yeah. Anybody have questions on that? No? Yeah? Yeah?
This clearly is hard to get numbers and that kind of stuff, but what are you all seeing in DC survival sex patients or clients that are doing this? And I would love to hear more about that.
Do you want to take a stab at that one?
Yeah, I can say that there are a very high rate, and again, I'm going back to youth of color because they are the ones that the least amount of research has been done on that. But what I have is data from when I actually worked at an organization that worked with LGBTQ youth of color who primarily, I was all over the District of Columbia consistently looking for housing for these young people. as well as these young people were HIV positive. And most of them became HIV positive because of this very reason. They were dealing with older adults, they had been kicked out of their homes, they were trying to survive, they would come to our organization for services, and that's one of the things that I know. So in regard to your question, I know that there is a very high rate of youth, particularly male and transgender youth, that are more so working in survival sex mode because of housing issues, because they don't really have a place. So they're either getting with older partners and sort of solidifying their living that way, or they, you know, they're house hopping from friends, or they're with this sort of gay gangs that they call houses, and they like have these big like gang or house balls, but they consider one another like family members who have sort of gone through the same thing, and they all just like come together and formulate this whole, everyone from the acronym, lesbian, gay, bisexual, transgender, intersex, or whatever, questioning, queer, whatever. So they have categories that they sort of compete against each other, and they do that. But that's their way of survival. They win money if someone says, well, you look more like a woman than she does. We're going to give you $500, that kind of thing.
And you asked what age before. It can be any age.
Oh, yeah.
When you think about how old people are when they're coming out to their families, you know, it can be any age, probably high school. We had two people recently that came in within 1 week of each other because they had both come out to their parents and they had both been kicked out, and they came in asking us, do you know of any resources where there are beds available, but they're under 18, so
right.
that pool limits itself. I mean, there are so many wait lists going on throughout DC that are months to years long. And so when you're under 18 and you're kicked out of your house, it's illegal, right? Meaning that there aren't that many services available to young people for those under 18 cases for a bed to sleep in or any type of emergency housing, which makes it even more challenging because if they're not allowed to go to their house and they can't find another place to, and they can't find any type of housing, actual like provided housing, and you know, it's like a random day where maybe none of their friends are answering their phone, then they're at high risk for sleeping on the street or participating in different types of survival instinct modes, like having sex with somebody just because they need that quick fix, try and figure out where they're sleeping right now until they can get better services. Yeah.
How does the foster care system function to that?
I mean, foster care system? Sure.
Sounds like it would be, you know,
well, that's where they're going to end up.
So, yeah. So the process for any type of mandated reporting is that you would contact the police, who would then contact the FSA, who would then assign a case manager to it, and then circle back with you. You know, there are cases where this can happen really quickly. I don't know that side of things very well, but I do know that more often than not, it's going to be really challenging, even if you have a case manager involved from the first second the person gets kicked out of their home, to really find them emergency housing.
And usually,
so limited.
Yeah, and usually what happens when you do the mandating reporting piece, and you generally have to do that while the client is there, because the police are going to have to come. Maybe there can be some negotiation with the parents, and the police would be able to facilitate that. If there's no means or ways that they are able to facilitate that negotiation, the person has to be, the young person would have to be like taken to the court, to the police district, and then that's when CFSA would get involved. They would get them a bed for the night, and then they would kind of start that process.
You know, we have clients all the time that come in and just like under so many different circumstances, not even just being kicked out of the house, but through a series of circumstances, they don't have a place to sleep for an entire weekend. And it's a Friday when they're telling you this at 6:30 at night when a lot of places are closed, and I'm racking my brain trying to think of any like viable resource, even within what are your friends doing, and can't get in touch with the friends. Well, how much money do you have? Oh, I have, you know, $10 in my pocket to last you an entire long weekend. And, you know, it's just like the circumstances keep coming, so it just becomes really challenging.
And not only so I've had several clients that were put out because they were like 15, 16 years old, and their family put them out when they disclosed they were HIV positive. So,
and that segues directly into this part, which is, you know, not only if we're thinking with one hat on like survival sex and risky sex in general, on the other hat we're thinking of if you are HIV positive, if you are diabetic, if you have an STI, you need a place to store your treatment or your medication and consistently and comfortably be able to take it. If anyone knows about HIV transmission, they know that if you're connected to care and you're on treatment, sometimes you're handed an array of a cocktail of different medications that you have to take at very specific times of day. Otherwise, you could increase your viral load. So if you don't have a consistent place to take that medication, then that proves to be a really, really big barrier for you raising your viral load and then possibly having other issues alongside of that. And then finally, you know, just touching in the back to HIV and STI transmission, we talk about sharing needles as a really high risky behavior with transmission. And with transgender young people, you know, any type of sexual reassignment surgery is going to be very costly. Hair removal, you know, taking hormones, trying to actually physically transition. And so oftentimes we hear about these back alley procedures where you're sharing needles for hormone injections, for silicone injections, things like that, which can be very, very detrimental to your health. Dangerous too. So, practices. Any questions on housing instability? I know we have 5 minutes. We have 5 minutes. If you have questions, come up to us afterwards.
Do you want to go over this, or just best practices as a provider?
Providers is probably better for everyone, right?
Yeah.
Okay.
So
best practices as a provider. So addressing the client is really important, especially when you're working with transgender clients. You want to make sure that you are asking the right questions. This isn't on there, but, you know, asking, if your client is having sex, don't ask them, are you having sex? Ask them, what types of sex are you having? Because you want to make sure that you're getting at offering them the most comprehensive care that they can get. And if they think that they have an STI and you check them with a pap smear, a woman with a pap smear for an STI and nothing comes up, well, did you make sure that she's not also having oral sex or anal sex? Because you can get STIs there as well, right? Simple things like that. When you're addressing the client, please don't be afraid to ask them their pronouns. People who are transitioning and are very open about transitioning are very receptive when you are trying to go the extra mile to make them feel comfortable in your office or in your setting. You know, there are constantly times where people, maybe their gender or their sex looks ambiguous to some, and by just referring to them as you assume they are, actually can really hurt them and then, you know, cut the confidentiality between you and your patient or your client anyway. So asking them their pronouns, like, hey, how can I refer to you? I refer to myself, and please refer to me as she, her, hers. Do you want to be he, him, or his? Do you want to be they, them, or theirs? People are very open to wanting to explain that to you. On that note, also the name. We have clients that come in and they change their name every single time they come in. That's cool. As long as we are up to date on what you want us to call you that day, then that's great. But just, you know, making sure, like, if you call them by their name and they say, please don't refer to me as that, well, refer to them as the name that they ask you to. Sometimes we ask on intake forms, you know, what is your name? And then what do you want to be called as? And so it's really easy. You look at it and say, okay, well, your name is Nicholas, but you want to be referred to as Nikki. Got it. I'll call you Nikki from now on. Don't be afraid to ask, just reiterating that it's better to ask and to make somebody feel more comfortable by asking and having them let you know than to just assume.
And just to reiterate, a very diplomatic way that we come up with is just asking a person, what is their preference? What is your preferred pronoun? What is the preferred name? What is, being able.
What can I call you?
What can I call you? Yes.
Being knowledgeable about transgender issues and LGBTQ issues, just being up to date. You guys are in trainings like this. This is always helpful, but also just reading about what's going on in the news is really helpful. Having LGBTQ-friendly paperwork, posters, rainbows, all of that stuff around your office is also helpful, so they know that they're coming to you and that they can open up to you and offer you more comprehensive answers to what you're asking. Focus on care, not curiosity. Obviously, when people are going outside of the norm, we tend to think, well, I wonder what's going on with them in their mind, or what their genitalia looks like, even though they're expressing themselves in one way or another. And if that is not pertinent to your job, whatever your job is, then do not ask, because that's just an invasion of privacy, and that can be really hurtful. Disclosure, the same confidentiality policies apply for any type of client provider situation that you're in, making sure that you are maintaining their right to explain to you what they are and not turning around and being like, well, they're transitioning. They started hormone therapy last week, right? If people don't need to know, then you don't need to tell them. And then don't interview with a parent in the room. Sometimes sometimes youth may have questions, or they may want to tell you something that they haven't relayed to their parents yet, and so making sure that you have that dialogue with them and that space for them to open up to you about how involved their parents are, how supportive their parents are at whatever stage they're in. That goes down to also don't dismiss parents as a source of support. That's really important. Parents can be really on board with however their child is feeling, but you want to see where everybody is at. Don't assume name or pronouns. Don't assume gender identity and expression correlate, and more importantly, sexual orientation correlates. Don't disclose anything without the patient's consent. Don't dismiss as a phase, as we talked to before, and don't try and refer to any type of reparative therapy. Don't send them off to a camp where it's a very religious affiliated camp and it's like, well, they'll change you. Any questions? No?
All right.
We are done. Thank you very much for your time. This is our email addresses if you have any other questions.
And if you guys be sure to fill out your evaluations.
Yes, the white evaluations are really helpful for us.
Thank you all. That concludes our Adolescent Reproductive Health Symposium for the day. You are free to go after the conference. You can just take the elevator straight down to the first floor. If you don't mind, we have a bin over there where you can put both the white and color evaluation in the bin, and we'll make sure that we just get them quickly. That's correct. And CME will be done online. It's the last item in your folder right behind the colored survey.